Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. This is episode 3 of our series on CMV and kidney transplant. Building on part 2, we explore patient cases to see how our faculty would individualize their CMV management. Once again, I'm joined by Dr. Marcus Pereira from Columbia University Irving Medical Center in New York and Dr. Raymund Razonable from the Mayo Clinic, College of Medicine and Science in Rochester, Minnesota. To see the full program and the previous episodes and the accompanying slides, visit the show notes. And now, here's Dr. Razonable.
What Dr. Pereira had mentioned are basically the standard of prophylaxis and preemptive therapy, but is there a way to individualize each approach? We're going to go through a couple of cases that I'm going to ask Dr. Pereira to respond as to what he does in his practice. So you have a 44-year-old seronegative man with a chronic reflux nephropathy received a kidney allograft from a positive living donor. So it's D+, R minus. Okay. He received induction with alemtuzumab and currently was maintained on mycophenolate, tacrolimus, and prednisone. Based on what you told us, what is going to be your prophylactic or preventive approach?
Very high risk, as we talked about, so you certainly need to consider some strategy. I think most often what we do in these situations would be prophylaxis as opposed to a preemptive approach. So certainly letermovir or valganciclovir are your options here for prophylaxis.
Okay. Are you going to do any monitoring during prophylaxis with CMI, for example, or...
So for D+ R minus, and I can't wait to hear what you will say, for D+ R minus, CMI is not necessarily a good strategy. It doesn't really work. So we don't do that. We also do not monitor PCRs while a patient is on prophylaxis. But for these types of patients who are worried about reactivation, especially that post-prophylaxis CMV reactivation, we do a hybrid approach where for these patients, we give them 6 months of prophylaxis and then monitor their PCRs afterwards to make sure those patients are not reactivating.
All right. Thank you so much. I agree with you. CMI to guide prophylaxis in this particular setting of D+ R minus is not going to work because the CMI will be negative for as long as you give the prophylactic drug. The question of hybrid approach wherein you do surveillance after prophylaxis is something that is recommended for high-risk patient population. And I don't know whether this was done in this case, but to move on 9 months or 3 months after, the patient required augmented immunosuppression because unfortunately developed acute cellular rejection. Are you going to do anything in this situation?
So remember, if they get augmented immunosuppression, especially in these high-risk patients, the risk for CMV comes back, right, almost after transplant. So this is a situation where you should strongly consider putting them back on prophylaxis.
Yeah, and this is particularly so if the treatment for rejection is going to be a T-cell depleting agent, then strongly consider you could do approach of prophylaxis or preemptive therapy. But in that setting, it is individualized based on what is available in your center. In our center, we actually do prophylaxis. Usually, again, restart that for a minimum of 1 month, as long as 3 months after an episode of rejection. In this case, CMV is detected and the patient was treated appropriately with ganciclovir.
So the question then, and I can't wait to hear, is secondary prophylaxis, right? So there are times when we do consider it.
Now, the second case is that of a 78-year-old seropositive woman. So this is now R+, with end-stage renal disease due to diabetes, received a kidney transplant from a positive donor. So it's a D+, R+. Induction was with thymo. The patient developed delayed allograft function and maintained on mycophenolate, tacrolimus, and prednisone. What's your CMV prevention approach up front?
Yeah, so my thoughts would be, again, the patient intermediate risk but did receive thymoglobulin. You do have several options in this scenario. Certainly preemptive therapy is a potential good strategy. They're intermediate. Prophylaxis is also a good strategy, whether it's with valganciclovir, which is usually what's approved for these R+ patients. Remember, letermovir is not approved for a D+, R+, or someone who's intermediate risk, although some centers do use it off-label. This is also a case where you could, if you do choose prophylaxis, CMI, and I can't wait to hear about that because this is exactly the patient who you don't know what is their pre-existing level of immunity. The other point is because of the delayed graft function, I'm imagining their kidney function is not great. So you really have to keep an eye on monitoring the creatinine clearance and adjusting the valganciclovir. If you choose to give them prophylaxis, keep monitoring the creatinine clearance and adjusting the dose.
All right. So a few pearls there really in this case is R+. The only approved prophylactic drug here is valganciclovir. But the caveat there is the delayed graft function, which basically makes dosing really challenging. And then there's also emerging data now that if you use prophylaxis among seropositive kidney transplant recipients, if CMV, CMI is available in your center or in your practice, you could actually use that to maybe potentially shorten the duration of prophylaxis as soon as you see that there's positivity for cell-mediated immunity. In this case, the patient did develop recurrent episodes of CMV reactivation, eventually treated with maribavir because of ganciclovir resistance in this situation. And the next question is, after that, do you give secondary prophylaxis?
A lot of valganciclovir, right? So put them at risk for CMV resistance. So if they're appropriately treated with maribavir, the secondary prophylaxis discussion is quite rich, and some patients or some experts advocate or not, and we don't really have a lot of data. But certainly someone who is at high risk or has developed a more complicated virus to treat, you might want to consider giving them secondary prophylaxis. In this case, valganciclovir is not an option, right? It's already resistant. So you're really down to letermovir for prophylaxis.
So really, after the course of prophylaxis that Dr. Pereira had discussed, the risk is really the late onset. And transplant patients that are at high risk for developing late onset, what I usually call the late onset post-prophylaxis CMV disease, are those that are mismatched, D plus R minus, those that are having augmented immunosuppression, those that have rejection treated with intensive immunosuppression, as well as those with low absolute lymphocyte count. So I always ask everybody when they discuss CMV with me is, what's the lymphocyte count? This is something that is available in every CVC differential. Look at that L. No, is it over 1,000? Is it less than 500 or things like that? Because it matters. If the lymphocyte count is less than, in my studies, less than, to be specific, then the risk for recurrent CMV, relapse CMV is very high. So one of the approaches to further individualize prophylaxis and preventive approach is the so-called surveillance after prophylaxis. We did allude this to earlier, wherein patients who are considered high risk, they are mismatched, D plus R minus. They have a very low lymphocyte count at various standpoints. They got induction with T-cell depleting agents. You know that they're going to be at high risk for CMV reactivation when you stop the prophylaxis. So one of the approaches is, can we measure PCR viral load once a week? Usually the recommendation is once weekly for 8 to 12 weeks to catch CMV reactivation that happens after prophylaxis. And in a study that was just recently conducted among kidney and liver transplant recipients, this approach actually resulted in improved graft and patient survival in the long term. Now, we talked about augmented immunosuppression. That first case wherein at 9 months, the patient developed rejection and was treated, particularly when the treatment is with lymphocyte depletion, like alemtuzumab, for example, or thymoglobulin. Or if you're using a second signal inhibitors like belatacept and other potent immunosuppressants, you really have to kind of consider that your patient is high risk for CMV disease. And the approaches there are either prophylaxis, if you really think that the risk is very, very high, or you could do CMV surveillance to catch CMV reactivation early on if that is the approach that is available to you. And then there's the so-called cell-mediated immune assay. This is an assay that is actually more available outside of the US. It's available in Europe, in Asia, in Australia. But the general principle is, if you can demonstrate CMV-specific cell-mediated immunity in the blood of your patient, the risk of CMV is low. So can we adapt that into clinical practice? And if it is absent, then the risk of CMV is high, and that will require either prophylaxis or more intense monitoring, for example. And some of the potential uses are, can we use this to guide primary prophylaxis duration? Can we use this to assess on whether we need to give secondary prophylaxis and things like that? So these are actually a group of various studies And what they've demonstrated is the absence of cell-mediated immunity at the time that they stop the prophylaxis translated to high risk for CMV. So you could do this regularly and see that if you demonstrate that the CMI is positive, let's just say duration, let's just say 6 months. If that is your prophylaxis, you do CMV CMI. If the CMV CMI is positive, you stop. But if the CMV CMI remains negative at that time, then the duration of prophylaxis can be extended. Now, the second group, shortened duration, this is a study that was done predominantly in abdominal organ transplants and kidneys, particularly wherein they looked at CMV CMI monitoring, and they were able to reduce the duration of prophylaxis among seropositive. So this is now R plus patients from a standard 90-day duration. In one study, they cut it down to about 60. So that basically saves you at least a month of prophylaxis, saves from toxicity from, for example, valganciclovir. That's what is being used for treatment. So take-home points here, there's been several studies, even randomized controlled studies that has been done in the past few years, demonstrating that these assays, if they are available, can guide you in assessing the risk of CMV infection, assessing the duration of prophylaxis, and we'll also talk about something wherein it helps with the risk for assessing secondary relapse and the need for secondary prophylaxis. This does not work for mismatch, unfortunately. In our high-risk D plus R minus patient population, CMV CMI rarely turns positive as long as they are on antiviral drug. Simple explanation is the antiviral drugs are so effective in suppressing the virus to undetectable levels. They don't reactivate. So our immune system is not seeing the virus. So our immune system is not primed to develop T-cell immunity. That's really the reason why these assays do not work to guide prophylaxis in mismatched D plus R minus solid organ transplant patients. So here is an algorithm as to the role of CMV-CMI in CMV prevention. And you choose to do either antiviral prophylaxis or CMV surveillance or preemptive therapy. Let's just say you choose antiviral prophylaxis for your patients. So you give the drug, administer it for a duration that is either 3 months or 6 months, depending on the risk profile. And during those times, you check CMV-CMI. And as soon as you demonstrate that the CMV-CMI is detected, then the risk of CMV is low, then you can safely discontinue antiviral therapy. If, for example, the option is preemptive therapy, then you do weekly CMV PCR testing. And as soon as the CMV DNA is detected, you can actually guide subsequent course of treatment there by checking CMV-CMI. If the CMV-CMI is detected at the time the viral load is detected, the risk of severe disease is probably low. So you can ensure that the patient is probably going to either spontaneously resolve the infection or get treated with short courses of antiviral therapy. However, if when the CMV PCR is detected and the CMV CMI is also not detected, then this basically is a high-risk patient for severe complications, and you are advised to be more aggressive in terms of treatment for the situation. What about the use of CMV-CMI in patients who have developed CMV disease or active infection? This is a relatively small study, but it basically brings home the point that patients are treated standard of care either with IV ganciclovir or valganciclovir until they clear the virus, they resolve their symptoms, the viral is now undetectable. At that time, this study looked at CMV-CMI and divided the patients into those who have a positive CMI at the end of treatment and those that are negative. Here, the positive CMV-CMI assay, the risk of CMV recurrence is 0. But for those with CMV-CMI that is not detected at the time that even their viral load has been undetectable, the risk of CMV recurrence is high. So this is a potential for guiding high risk of relapse and potentially the need for secondary prophylaxis. And this is actually what was done in this other study of relatively small group, 27 solid organ transplant recipients. They have CMV viremia. They got treated with ganciclovir or valganciclovir until the viral load is no longer detected. At that time, CMV-CMI was measured. Those that have a positive CMV-CMI test, the risk of relapse is very, very low in the absence of secondary prophylaxis. But for those with negative tests, the risk of CMV is still high despite the fact that these patients receive secondary prophylaxis. To me, this means that these patients are highly overly immunosuppressed. So in addition to secondary antiviral prophylaxis, in this case, you could use valganciclovir or letermovir if that is an option. You also have to ensure that the patient's immune responses are recovering by reducing immunosuppression. And with that, this is an algorithm to the use of CMV-CMI in CMV treatment. So if you have a CMV diagnosis, you do your standard of care, monitoring with viral load, monitoring with CBC creatinine, and assessment of clinical status. And as soon as the viral load is no longer detected, the advice is, if this is available, check your CMV-CMI assay for your patient. If it's detected, nothing to worry about. The risk of relapse is almost zero. No need for secondary prophylaxis. If after a treatment of CMV disease, the CMV-CMI remains negative or undetected, then you consider secondary prophylaxis because the risk of relapse is very high. And at the same time, you also talk to the rest of the team is there a way to further cut down the immune suppression? Because even if this patient has been exposed to, let's just say, 1 million copies per ml of CMV, and they're still not recognizing it, their T cells are still not recognizing it, that means that those T cells are really kind of anergic. That means that the immunosuppression is probably too much. So secondary prophylaxis is an approach to prevent relapse after a primary infection. The drugs that are used in practice is really valganciclovir. You could see uses of letermovir as well. I've seen some cases wherein maribavir was used, depending on resistance patterns. And this is really important. But the data out there on whether it's effective or not in preventing relapse is all over the board. And this is because those patients are not properly selected as to who gets secondary prophylaxis or not. If you choose it correctly, it could potentially work. But there's also evidence that it may actually be better in the long term with improved survival compared to those who did not receive secondary prophylaxis. So what does the guidelines say? Since there is no prospective randomized trials to determine on whether secondary prophylaxis is effective or not, a poll of the contributors to the international guidelines was conducted. And those experts do recommend that you consider secondary prophylaxis if your patient is considered high risk for relapse as defined here. If they're mismatched to start with, if they're lung transplant recipients, if they have a high viral load at the time of presentation, if there's been recent use for lymphocyte depleting agents, if there's a recent history of augmented immunosuppression, if their lymphocyte count is very low, in my view, that's anything less than 750 is low. If their cell-mediated immunity is undetected against CMV, and if they've had really prior recurrent CMV infections, those are some of the clinical variables that will guide you on whether secondary prophylaxis is used or not. And the choices for secondary prophylaxis is either valganciclovir, and if there are concerns for that because of drug resistance patterns or drug toxicity, then letermovir may be used as an off-label, noting that there's no drug really that's approved for secondary prophylaxis. Even Valsite is not approved for that. We just use it off-label. Okay, so take-home points. Prevention of CMV improves the outcomes of kidney transplantation, overall outcomes, not only infection-related outcomes. It's all outcomes, including low risk for rejection, as you demonstrated. Both approaches, preemptive therapy and prophylaxis, are equally effective for CMV disease prevention. Prophylaxis is easier because we give the prescription. You forget about it. But with preemptive therapy, you really need the logistics of having people monitor the viral load, make sure that it gets done every week so that you catch the virus when it reactivates. Valganciclovir and letermovir are similarly effective as prophylaxis in D plus R minus kidney recipients. They've been demonstrated to be equally efficacious. Safety profile favors letermovir. Cost, however, is going to be also a player in the decision as to which drug to use. And then individualized approaches to CMV prevention is coming. It's on the way. There's been more work done on CMV-CMI that will help us standardized, durations of treatment as well as prophylaxis based on the interplay between the virus and the immune system. I'll turn it over to Dr. Pereira.
Thank you so much. With that, we get to answer questions. I think some came over,
yeah,
right?
Yeah, I'm going to ask you. I asked the question, you answered them all.
Oh,
Okay.
Very good. Okay,
All
I'm
right.
happy to do that.
So the first question is there a recommended minimum interval for CMV CMI monitoring?
That's a good question. We talked a lot about CMI testing, and studies have been all over in terms of the timing, right? So some studies have done pre-transplant CMI monitoring. Some have done 1 month, 3 months. And then when we talk about secondary prophylaxis, obviously that's a different time frame. The one that I've seen, and based on the guidelines, we could not give the sort of determined timeline on when to do it, but there was a suggestion that perhaps at month 1 post-transplant was a reasonable, at least first test. As far as the interval between tests, there were some studies that were checking each month, so perhaps once a month, until your patient is found to have a positive response. You want to get to that positive response so then you can stop prophylaxis.
Yeah, I completely agree with that. Most of the studies that have actually assessed at maybe shortening prophylaxis among seropositive kidneys, let's just say focus on kidneys, among seropositive kidneys. So the standard duration is 3 months of prophylaxis, right? For that. But if you want to potentially maybe reduce the duration, you could do it once a month. And if I remember correctly, the majority, over 60% of patients will have reconstitute their CMV-specific immunity by month 2. So you could potentially stop prophylaxis in 60% of your patients if you demonstrate that by month 2 or something like that. Now, on the other side, let's just say lung transplant, wherein whatever you do, you cannot convince them to stop prophylaxis,
You are not going
right?
to stop.
So you set a minimum, like for example, 6 months. So you give prophylaxis for 6 months, and then, at least in our program, and then measure CMV-CMI at 6 months. If it's positive, then that's your argument, you can stop.
Yeah.
Right?
Yeah.
But if it's still negative, you can actually ask them to continue.
Yeah.
Because the risk of CMV is still there.
That's a great approach.
That's great.
We're trying to convince our heart transplant team to adopt
You are?
that.
Okay.
Yeah.
All right. Another question specifically for you.
Okay, very good.
Can we use ALC instead of CMV-CMI, and what is the cutoff value?
We talked a lot about that with the guidelines. There was a strong argument that, one, it's cheaper, very much accessible to all of us. It's interchangeable, right? Like you go to different labs, you're going to get the same ALC. So there's certainly a good argument for that. Now, there haven't been, I don't think that there have been any randomized control studies to the level that the CMI tests have now been conducted to show that it's sort of an equivalent measurement of cell-mediated immunity. I think it can help you guide decisions. And certainly, actually, if you have an ALC that's less than 600, for example, CMI tests may not work, right? Like you're too leukopenic in a sense for your interferon gamma release assay to work. So I would say there is some evidence, and it's not as strong as CMI, but it's a very intriguing approach for sure. I have used it at times for secondary prophylaxis.
Yeah.
For sure.
Yeah. It's part of the whole picture, is what I say. So, there's a number.
Okay.
610 is what you say. But you use that number as part of a bigger formula. Has the patient had rejection in the past? What's the level of immunosuppression? Are you still aiming high on your TAC level and things like that?
Yeah.
If all those things kind of point to the fact that, this patient is still highly immunosuppressed, and then that will be a high-risk patient to begin with.
So you're not mad at me for what I just said, right?
Nope.
I mean, Raymund conducted a great study.
Yeah. No, and I echo your suggestion there too, that if your ALC is, in my practice, if my ALC is 750 or less, I don't even bother sending a CMV-CMI test because that's going to be a waste of money because it's not going to be positive.
Good.
Yeah.
Okay, I have a question for you.
Okay.
I think I saw it in the audience. So when it comes to letermovir prophylaxis, how do you approach HSV and VZV prophylaxis? That's not something we talked about, but it's important for everybody.
It is important. So letermovir is active against CMV. It does not have activity against herpes simplex or varicella zoster. So really important to remind everyone that if you use letermovir for prophylaxis in your kidney transplant recipients, do not forget to also give acyclovir or valacyclovir.
Valacyclovir, yeah, or acyclovir. Yeah. That was important.
That concludes it.
I think so.
Thank you to our faculty, and thanks to you, our listeners, for joining us. To learn more from our program on minimizing CMV and high-risk kidney transplant recipients, click the link in the show notes. And to get access to all of our new podcasts, you can subscribe to the CCO Infectious Disease podcast on your favorite podcast player. Thank you, and we'll see you on the next podcast soon.